Well, we all know the significance. This is me. I'm in Sunshine Hospitals doing the entire gamut of electrophysiology. We all know the significance of atrial fibrillation and the incidence and prevalence of which is rising day by day. We also know the morbidity and mortality it brings with itself. So jumping into the topic, I'll just deal with a little bit of anatomy relevant to ablation. And as is shown here, we should know that there are phrenic nerves which run along the heart, especially on the right side. It is adjacent to the right pulmonary veins. And we can have phrenic nerve injuries during ablation in these areas, so we need to be careful. And next is posteriorly, the esophagus is quite close to the posterior wall, as is the aorta, as can be seen here. So atrioesophageal fistulas or aortic injury is a possibility, though very rare with the recent technological improvements. Other point relevant to ablation is that the left atrium is not a very smooth structure. It has a lot of muscle fibers, and we don't know where and what is the extent of these fibers, but definitely they help in perpetuating the atrial fibrillation. Some more anatomy. This is on CT or MRI, which we usually do before ablation. Most of the patients, about 80% of them, have four separate pulmonary veins. There's the left side, this is the appendage, and the right two veins. And in about 15 to 20%, there can be supernumerary veins, as is seen here, or there can be a common ostium, as is seen here, either one side or bilaterally. There can be a common trunk, and there can be a massive left veins with a deep ridge, which all make ablation a little more difficult, and that reflects into the success of the procedure. There are some hypotheses that I would like to touch upon because this also has a bearing on, where's the pointer? Yes. On the type of lesions we create. There's the multiple wavelet hypothesis. There is a focal automaticity hypothesis. Then there's a focal re-entry with a fibrillatory conduction hypothesis. Then there is functional re-entry hypothesis. And with all these hypotheses, what maintains is the hypothesis that says there is a dissociation between the epicardial and the endocardial layers of the atrium with mutual interaction, which leads to multiplying activity and maintenance of atrial fibrillation. So these are all important mechanistically. And another way of looking at it is the structure and mechanism. This is the postero-anterior view. You can see the left atrium here and the right atrium with the SVC and IVC here. The heart has four or five groups of sympathetic ganglia. That is the superior and inferior right and left. This does not have a pointer, okay. And also along the vein of Marshall. And I'll speak like this, yes. And there are some minor and larger rotors which sustain the atrial fibrillation. And the most common foci of origin of AF are the pulmonary veins in about 85%. And in the remaining, there are foci which are on the posterior wall and on the intraatrial septum, on the RA free wall, coronary sinus ostium, SVC, etc. So what do we do? What are the modalities available? There are two most common modalities utilized around the world. And in India, we only have radiofrequency ablation, which is still the gold standard. We put in these spiral catheters in the pulmonary veins, in the four pulmonary veins, see where they are connected. There are different schools of thoughts, but I usually follow the most commonly followed one, that is wide angle circumferential ablation. And we go point by point and ablate and get rid of these muscle sleeves which connect the pulmonary vein and the left atrium. These muscle sleeves, subject to stress, start firing, and that is what we want to silence. And there's also cryo ablation, which is supposed to come to our country. Way back in 2014, we published a 3-year follow-up of cryo ablation with the old generation balloon. At 3 years, we had 57% in sinus rhythm free of antiarrhythmic drugs. And that was confirmed in Fire and Ice study, which was a randomized large trial, which said that the cryo ablation is non-inferior to radiofrequency ablation. And what do we do in AF ablation? Using radiofrequency ablation, we do what is called the wide-angle circumferential ablation. We isolate the pulmonary veins. In persistent AFs, we go and do the mitral isthmus line. That is from the Vaka line, we join it to the mitral annulus, and there is a roof line that we do, and also the anterior line that can be done. There is a isolation of the posterior wall using box lesions. There can be carinal lesions, SVC isolation, etc., etc. And there can also be complex fractionated atrial electrogram or CAFE ablation, which is especially in long-standing persistent AFs or redo procedures, these are helpful. And what is the cornerstone of AF ablation? That is pulmonary vein isolation still, and adding other lines or CAFE ablations adds little unless it's a redo procedure. So class 1 indication is to do pulmonary vein isolation and confirm entrance block. We all know the risk factors for AF: obesity, sleep apnea, hypertension, diabetes, alcohol, exercise, etc. And the control of risk factors definitely has a significant impact on AF burden. As was shown in one of these studies, with each tertile of weight loss, there was a significant decrease in AF burden. And other benefits of AF burden, there's always a quality of life question with any procedure that we do, and AF ablation has been shown to add to the quality of life in terms of decreased anxiety, decreased depression, physical and mental improvements on quality of life scores. And there's also decrease in hospitalization, decrease in stroke, etc. And what do the guidelines say? This is the 2017 guideline, which gives class 2A indication for atrial fibrillation ablation in paroxysmal as well as persistent atrial fibrillations conditions. But then long-standing persistent AFs, it is class 2B. But what is class 1 is still antiarrhythmic drug. Why is it so? Because mortality benefit still has not been shown convincingly in randomized trials, and there are trials which are coming up which probably will push AF ablation to class 1 indication in early persistent and paroxysmal AFs. And what is the proof to give a class 2 indication? There was a meta-analysis which was published in 2009 which showed the odds ratio of having been AF free at 12 months in the range of about 15 to 20. That's a huge benefit. And likewise, RAF2 trial published by the US group showed that RF ablation scores over antiarrhythmic drugs even as first line. And next is Mantra PAF. This was by the Danish group, Carl Nielsen, published first the 2-year follow-up in NEJM and then followed by 5-year follow-up, which were consistent, and the ablation benefits were sustained. That is, freedom from any type of any AF or the freedom from symptomatic AF were significantly more or better in ablation group. So with all this, this acted as a proof for giving a class 2A recommendation. Now, coming to other not well represented clinical groups like congestive heart failure, old patients, hypertrophic cardiomyopathy, young patients, tachybrady syndrome, athletes, etc. They all have class 2 indication. I will not go into this. I just want to show you in asymptomatic AF, when we do something, the patient has to live better or live longer. In AF, in asymptomatic, that was not shown in 2 of these trials. So it is a class 2B indication still. Is it a bluff, or is there really, is it a reality that we do? This is one of my patients who came recently for a follow-up. It's been 4 years. His name is Ram Narasimha Reddy because, I remember him very well because every year he gives me a gunny bag full of sweet lime. And these are the 4 veins that are shown on these are right veins, and that's a left superior, and this is the left atrial appendage. He has an elongated atrium, but not very globular. This is the mitral annulus. This is how the left atrium looks. And here you can see that the left pulmonary veins are being isolated. I'm doing the ablation at this point. As you can see, these things are all atrial firing, the PV firing, and then it becomes silent. So that means we have dissociated the left atrium from the left ventricle, left pulmonary veins. And then likewise on the right side, Here near the blue dot I am ablating, and the right pulmonary veins are again isolated, but the arrhythmia continues, but it regularizes into a mitral left-sided arrhythmia, which further ablation into, I did the mitral isthmus line, and followed by a right-sided isthmus line. This is again the right-sided flutter. It's all in the same patient. I have done the roof line, mitral isthmus line, then right-sided cavotricuspid isthmus line, etc. And this again, just 2 more slides, please. And the patient returns, and after this, there is a flutter ablation, and the patient returns to normal rhythm. And this is the final result of sinus rhythm. The take-home points of this talk is that paroxysmal AF class 2A, persistent AF class 2A, long-standing persistent AF class 2B, asymptomatic AF class 2B. What is pending is mortality data from Cabana and East studies, etc., which could push ablation to class 1 indication. And this is for those of you who have not seen Professor Brugada, who described the Brugada syndrome. This is him. And this was in June, where I was in Vienna to write some exam. And thank you very much. Any questions, please?